Sir, good evening, sir. Dr. Rajiv, good evening.
Hello.
Good evening.
Muted, sir. Muted.
Rajiv TP is muted.
Good evening, sir. Good evening, Arun. Good evening, Pawan.
Good evening, sir. Good evening. How are you?
I'm fine.
How are you?
Fine. How are things in Delhi?
Delhi is fine, but number of cases increasing rapidly in our hospital. Almost all department doctors are infected in last 1 week.
Because
Doctors
of the festival?
or their families from many departments.
Because of the festival? Because of the festival?
Because of the crowd is back to the same as it used to be. People are coming now, OPDs are full, they are back to back standing and crowd, and they are crowding the doctors.
That is a big issue.
Yeah. Actually, our attendance, hospital attendance used to be 9 to 10,000 per day, and it had a drop to 1,000 around. And now it was going around to 3,000 per day. But suddenly it has come back, full strength.
So that safe distancing is not there between the doctors and the patients.
No. Now safe distancing is casualty. Only mask can protect you, nothing else.
Yeah, that's the thing. But still, even with the mask also, it should be made compulsory that the patients should also wear mask, and there is a
no, but how you will prevent the fomites? Their papers, their prescriptions, their articles, so many things are handled. And what is happening? Our DDA, the Deputy Director Administration, our Deputy Registrar, our 3 head of the departments. In one HOD is 10 family members. This account staff. So I think this all is happening because of movement of files also.
Yeah, file is another source. If you are not extra cautious after handling the file, then it is a very...
Yes, what I suspect, I also got from file only.
Because once you touch the file, you should not touch anywhere with your hand, unless and until hand is sanitized. But unknowingly, you forget. That is
what is happening.
Yeah.
So
I don't think vaccine will be there before July, August 2021. Yesterday, the news said that by February, that Covaxin will be rolled out to.
But now people are saying there are articles that this vaccine may cause genetic manipulation. And we have to be careful. It is banned in animals, and now we are experimenting on humans. This is RNA vaccine.
That's what where our experts will find out actually. But
so in any way, vaccine is not going to be available before mid of next year.
Yeah, that's what July, August 2021, it may be available.
Sir, it's also causing, so I know 2 people personally who developed diabetes post COVID.
Yeah, that is reported.
And
that is reported. Existing diabetes is becoming worse, and people pre-diabetic are becoming diabetic.
So
this is basically because of the remdesivir, steroids, and all used for a long time.
Yeah, steroids, heavy doses are used. I'm diabetic. I was taking medicine, but they suggested that I should take insulin during this period because my sugar started going 400, 450 on all the medicines which I was taking. So then I was suggested that take more medicine, insulin. That
Now
is
social distancing is not possible. I mean, आपकी OPD भी, our OPDs are back to same strength, 500 people. How are you? It's not possible to.
In RML situation is bad. We are short of space. Our corridors are narrow. Old building, 80, 90-year-old buildings are there. So we have problem. Our corridors, it is difficult to walk. You have to squeeze your way.
Sir, Sadalang भी same है. अब because हमारा super specialty block तो has been taken over by COVID, so we are also back to building. So it's the same now.
You are back to the same ward.
Sir, हमारा super specialty block तो is closed for the last 8 months.
No, but from where you are functioning?
We are functioning from the old OPD building. We have taken 2 rooms and we are only functioning from 2 rooms. So
What about the indoor beds?
Sir, 5 beds हैं emergency में. That's it. So urology is practically closed since March. I mean,
No, actually, my beds are divided 20 in one building and 25 in another. So I had given only 25 beds, 20 are remaining with us.
But you're operating then, urology?
We are operating 2 cases every day only.
So हमारा तो almost it's only emergencies, but work is practically finished.
We are mostly that too. Mostly we are operating malignancy and sometimes stone. All strictures, everything is postponed.
Everything is
whatever can be postponed is not operated.
We are doing everything.
So you're doing everything?
Everything.
I went to schemes, Srinagar. They are operating 5-6 cases every day and full-time emergencies, and they are operating more than normal times.
No, sir. Now, actually, our average list in OT consists of around 15 cases per day. Yeah. But we used to have 25 number to 30 number per day. So we are working only 40 to 50% of our normals.
No, but your hospital is also declared COVID hospital.
No, we have beds allotted for them. Our COVID hospital is district hospital.
Actually, what is happening, we don't have allotted any private rooms, but we have allotted our ICU beds. So if ICU beds are not there, then how you will operate? Anesthesia people are not cooperative in our case. All radical procedures, they ask for arranging ICU bed.
We have around 175 ICU bed. Out of that, I think 100 are marked for COVID only. 75 is for other disciplines.
How many beds are there in Manipal?
We have a 2,200 total bed.
We have 1,500 beds only.
Yeah.
So we can start, sir?
Yeah, you are good to go, sir. Okay, sir.
Yeah, Navneet?
Yes, sir. We can start.
Good evening, everyone. Chairman, Indian School of Urology, Professor Rajiv Sood. Co-chairman, Indian School of Urology, Dr. Arun Chawla. Faculty for today's program, Professor Pawan Vasudeva. And dear student friends. Today, we are having a very interesting topic. And we have none other than Pawan Vasudeva, who will be deliberating this topic and interacting with you all. This is on neurovesical dysfunction. It's a really very, very important topic for the MCH and DNB program, both theoretically as well as in clinics as well. Whenever there is a case of neurovesical dysfunction, this will be always there. So today, Professor Pawan Vasudeva will be deliberating on the various clinical aspects and will be discussing and interacting with all of you. I am happy that we have got Pawan today for this important topic. With these few words, I welcome you all for today for this USI Resident Smart Learning Program. Now I would request Professor Rajiv Sood, Chairman, Indian School of Urology, to say a few words. Over to you, sir.
Thank you, Dr. Rajiv. Thank you for a kind introduction of the program, and also managing all the hectic activities of Indian School of Urology while doing all the work of Secretariat of Urological Society of India. I'm very thankful to Dr. Arun Chawla also, who is continuously, tirelessly making all the efforts for delivering these lectures as the part of the knowledge effort. And in the era of COVID, our students have not suffered, our residents have not suffered because of these programs. And not only they have not suffered, they have got quality education and quality knowledge and quality teaching faculty who is delivering on the various topics of urological importance. And also this is an effort for uniform education, uniform curriculum across the country, across MCH and DNB students, and also a learning portal for young urologists and faculty. Now, the topic today is neurovesical dysfunction, as Dr. Rajiv TP has already introduced, that this is the topic which you are studying from your physiology days in MBBS, and also then you are interacting in your clinics, and when you are finally going for theory, you will be facing questions from this, and also in Viva and in the practical exams, you will be finding the patients. In clinics, this is very important topic and very interesting also. And I think for last few years, some faculty, the Indian urologists have made it more interesting, as Dr. Vasudeva is master of the craft and master of the this neurovesical dysfunction. It is the area of his interest, and you are all lucky that he is deliberating and on this topic, and has organized interactive learning session, which is the part of the distant learning. And it is the fourth pillar of our Indian School of Urology in Euromet program, that is virtual classrooms. So these virtual classrooms is the new norm, as many new norms we have adopted during COVID era. And this is one which we can be proud of, Urology Society can be proud of. And actually council and the program spearheaded by the ISU faculty with the great contribution from Dr. Rajiv TP. This is going on strength to strength. And with this, I declare this program open today and this class open. And I'll request Dr. Rajiv TP to introduce Professor Pawan Vasudeva, who is at Safdarjung Hospital and Vardhaman Medical College. And you all are aware about his interest and his contributions in this subject. Dr. Rajiv TP, please.
Thank you, sir, for your enlightening words. Professor Pawan Vasudeva doesn't need a special introduction. He is known to most of the residents. He is, in fact, the professor of urology at Safdarjung and Vardhaman Hospital and Vardhaman Medical College. He, as Professor Rajiv Sood has highlighted, is one person who is specifically interested in the field of neurourology. And he's a very active member of International Society for Neurourology. And he has readily agreed to deliberate on this topic. And we are glad to have him here specifically for this topic. With these few words, I would request Professor Pawan Vasudeva to take over for the further proceedings. Over to Dr. Pawan.
Good evening, everybody. Thank you, Dr. Rajiv sir, Dr. Arun Chawla sir, and Dr. Rajiv TP sir for this opportunity. And I will just, so how we planned this is, I'll just deliver a very small lecture giving an overview of the neurovesical dysfunction. And then we will have a couple of cases where we can have an interactive session, and we can discuss how these patients should be managed. So can I share my screen? So is the screen sharing?
Yeah, you can. Yeah.
Yes.
Yes. Fine.
So can we start?
Yeah.
Yes. Okay. Thank you. So we'll just go through what normal bladder function is and the relevant neuroanatomy related to the normal bladder functioning. Then we'll try to understand what happens with the different levels of injury, what is the related pathophysiology, and finally we look at the therapeutic targets and what is the outline of the options depending on what lesions we get. So if you look at the normal bladder the normal bladder function, you have essentially two phases. One is the filling phase and the other is the voiding phase. What we expect the bladder to do during the filling phase is that it should be able to store an adequate amount of urine with no sensation of filling. It should be able to store this urine at a low pressure, and the patient should be continent during this phase. So for this to be achieved, the bladder detrusor should be relaxed and the sphincteric apparatus should be contracted during the filling phase. The other phase, which is the voiding phase, what is the bladder expected to do? To be able to voluntarily initiate micturition, you should be able to void with a good stream without obstruction, leading to complete emptying within a normal time span. And the detrusor is expected to contract during this period, and the sphincter is expected to relax. So how do we, what is the neuroanatomy? I'm just going to touch on very, very broad points so that we don't get confused. If you look at the peripheral supply to the bladder, you have a sympathetic supply, you have a sympathetic supply, parasympathetic supply, and a somatic supply. The sympathetic supply is coming from this region, which is the lower thoracic upper lumbar region. And what the sympathetic supply is doing, it is quietening the detrusor during the filling phase, and it is causing contraction of the bladder neck during the filling phase. So this is essentially the nerve of filling. The parasympathetic supply comes from the S234 segment, and what the parasympathetic nerves do is they cause contraction of the bladder during voiding. So this is the nerve of emptying. And then you have the somatic supply again from S234, but transmitted through the pudendal nerve, which causes the external sphincter to contract. So this is also active during the filling phase. Now the micturition reflex involves this important center, which is called as pontine micturition center. The role of this pontine micturition center is to send stimulatory signals down so that the parasympathetic can get activated and the others can get quietened. So this pontine micturition center would be active when a person has to void. Now, during filling, this pontine micturition center is under tonic inhibitory impulses from above this. So if you look at, I've just made a small diagram to help you understand. The pontine micturition center in itself would send stimulatory signals down to help in voiding. But during the filling phase, this pontine micturition center is always under inhibitory control of the periaquital gray and also the input from the forebrain. So there is a tonic inhibition of this center. So inhibitory impulses go down, and that is what allows the bladder to fill and the external sphincter to contract during the filling phase. What happens during the voiding phase Why is this not moving now? Yes. So during the filling phase, the sympathetic are activated, the parasympathetics are silent, and the somatic is again activated. Now, what happens during the voiding phase? This tonic inhibitory impulses, which were coming from the forebrain and the midbrain to this pontine micturition center, they stop. So the tonic inhibition from the top stops, and this allows the parasympathetics to fire, the detrusor to contract, and the external sphincter to relax. So this is what broadly happens during, this is the neuroanatomy behind what is happening. Now, if we look at neurogenic bladder can be the kind of dysfunction that you get actually depends on the level of the lesion. So they are classically described as, you could either have the lesion above this pontine micturition center, you could have the lesion through the pontine micturition center, or you could have it below the pontine micturition center. When you have it below the pontine micturition center, it could either be infrapontine but suprasacral. When I say suprasacral, I mean the S234 from where the parasympathetics are arising. So it could be a suprasacral spinal cord lesion, or it could be a sacral spinal cord lesion where S234 gets involved, or it could also be infrasacral where there is a peripheral nerve injury due to some surgical cause, diabetes, or whatever. Now, depending on which area this injury happens, you can have patterns of neurogenic dysfunction. And whenever you address these patients, you should look at the bladder separately and the sphincter separately and try to understand what's going on with each of the two entities. So Professor Martersbacher had come out with this classification where the green signals a normal function, the thick black signals a overactive function, and the thin black function signals an underactive function. We will go through the as we discuss each level. We will go through these each of these dysfunction. This is called as the Martersbacher's classification, and this essentially allows you to tailor the management depending on what you get in each of these two components. So coming to the suprapontine lesion, if the lesion is through this suprapontine area, what essentially happens is that these inhibitory impulses which are coming from the top, this inhibition is cut. So if this inhibition is cut during the filling phase, the tonic inhibition that was being provided is gone. So what would that do? During the filling phase, that would make this bladder overactive, which means you would get detrusor overactivity. And the presentation of this detrusor overactivity would be the patient would present with frequency, urgency, and urge incontinence. An important thing in these suprapontine lesions is that because the pontine micturition center is preserved, only the tonic inhibition is lost. So the coordination between the sympathetic, parasympathetic, and the somatic is maintained, which means that the voiding will remain coordinated. And the only problem that these patients would have is that there is detrusor overactivity in the filling phase. So the voiding is right, but the timing is wrong. This is unlike the suprasacral lesion, which we shall come to. So the therapeutic target in these patients is that you want to control urgency, urge incontinence, and the unawareness urinary incontinence. And the options that you have is you have conservative measures which include bladder retraining, pelvic floor exercises, urgency coping strategies. Then you have antimuscarinics and botulinum toxin. Now, if the next lesion, if the lesion goes through pons or through the pontine micturition center area, now what happens here is a little unpredictable. They could present as a suprapontine lesion if the micturition center is preserved. It could present as underactivity if this pontine micturition center is directly damaged, Or if the lesion is a little below and the pontine micturition center gets preserved, then it could present like a suprasacral lesion, which is what is coming after this. So this is a little tricky area where, and this is the area which is affected by some Parkinsonism and multiple sclerosis patients come into this, so which makes urodynamics extremely important when you're handling these patients. So coming to an area where it gets clearer, suppose now the injury moves a little lower, so the pontine micturition center goes up and the injury comes below this. So this is the classical spinal cord injury where it's a suprasacral spinal cord injury. Now what happens here is, during the filling phase, we understand that these tonic inhibitions which were coming from the higher centers to the sacral cord will obviously be gone. But another thing which has changed when we compare it to the suprapontine lesions is that the pons, this has also got cut here. So the coordination that was happening between the parasympathetic, sympathetic and the pudendal nerves during voiding, that also gets affected. So you get detrusor overactivity due to loss of tonic inhibition as you were getting in a suprapontine lesion. But in addition, during the voiding phase, the sphincter does not relax. So you get what is called as detrusor external sphincter dyssynergia. So not only is this overactive, but here this also becomes overactive, and also you can get bladder neck dyssynergia. So not only is the so here the voiding is actually uncoordinated, and because of this uncoordinated voiding, this is a situation which is extremely dangerous, because this can lead to high pressures in the bladder, and these high pressures in the bladder in turn can lead to upper tract damage. So for these suprasacral injuries, the therapeutic target is first to protect the kidneys, which is to normalize the high pressure situation of the lower urinary tract by managing this, and also along with that to control the reflex incontinence. Now, how can that be done? Now, in this spinal DO or in the suprasacral patients, you have a dual problem. You have a problem of the filling phase as well as a problem of the voiding phase. The filling phase, the bladder is not quiet, and the voiding phase cannot void because of DEST. So what options do we have here? Option one is you make the bladder silent, or you improve the filling phase characteristics so that the kidney is safe. And for the voiding phase characteristics, you circumvent this voiding by introducing CIC. So what could be the options in this? You could quieten the bladder using an antimuscarinic, using botulinum toxin, or even an augmentation cystoplasty. We will come to all of this when we discuss the cases. So you could quieten the bladder, and so that takes care of the filling phase. And for the voiding phase, you could circumvent this by doing CIC. This is one way to deal with spinal, with suprasacral lesions. The other way is you actually address the detrusor external sphincter dyssynergia by doing a sphincterotomy, whether it's a electrical or a laser or with botulinum toxin. You address this detrusor external sphincter dyssynergia. When you address this, the bladder pressures automatically decrease a little, even though they may not come to normal levels. They will decrease a little, and but then these patients become incontinent and they have to be on a condom urinal. So the other option would be you do a sphincterotomy and put the patient on a condom urinal. This is only possible in men because you have a collecting device. It will not be possible for, I mean, it will not be advised for usually for women. The third option is triggered voiding, and the fourth option is to put them on either an indwelling urethral catheter or a indwelling or a suprapubic catheter. We will discuss all these four options when we take up the case, but broadly, this is how you would manage a suprasacral injury, with option one being the standard option, which is done. Now, coming to the last which is the sacral or the infrasacral lesion, which means the lesion has now gone through the S234. So even though the tonic inhibition is not there, but the area that had to actually work, which is S234, which had to go and contract the bladder, that itself is damaged. So what happens? One, the detrusor would be underactive. So this is essentially a voiding phase problem where the detrusor would be underactive or acontractile, and which will lead to incomplete emptying or can lead to urinary retention. The other thing that can happen is if S234, if the lesion is such that it does not affect the pudendal nerve and the supply to the external sphincter, in those cases, the sphincter would be normal. But the green represents normal, so the sphincter would be normal. But let's say the somatic S234 is also affected, then the sphincter becomes weak, and because of that weakness, you can get sphincteric incompetence, or what is known as neurogenic stress incontinence. So the therapeutic target in this population would be one. During filling, there is no problem. They allow you to fill. But during voiding, they will not empty. So one target is you would want regular bladder emptying without generation of high pressure. And I will subsequently discuss this in the case discussion, what this means. And also if there is any neurogenic stress incontinence, then you need to manage that. So the options for these patients would be a Valsalva or Creed, intermittent catheterization, an indwelling catheter, or surgical options. We will go through all of this. And for if there is a component of neurogenic stress incontinence, then you would need to be looking at a sling in women or a artificial urinary sphincter in men. Now, broadly, I will just take, I understand there is a urodynamic session which is scheduled. So I'll just spend one slide on how you need to evaluate these patients. So routinely you will do culture KFTs and non-invasive urodynamics, which would include a bladder diary, a post-void residual urine, and a uroflowmetry. But the gold standard remains invasive urodynamics. Now there is a discussion regarding whether all neurourological patients should undergo urodynamics, or can you tailor it to from a patient-to-patient basis. So there is still it is still evolving how you need to deal with them. But how I take it is, one, you look at the nature of the disease. So if the disease is such that the risk of upper tract damage is high in general in that disease. So for example, suprasacral injury, spinal cord patients, patients with spina bifida, patients with anorectal malformations, these patients, the incidence of upper tract damage is fairly high. So uniformly in these patients, you should be doing a baseline urodynamics, because it will allow you to assess the risk to the upper tract. There are some diseases like stroke, the incidence of or a suprapontine lesion, where the incidence of upper tract damage is not that much. Now, ideally, if you want to manage those patients objectively, you would need a urodynamics. But there are people who would, start a patient of stroke with urge incontinence on an antimuscarinic without doing a urodynamic, because the risk of upper tract damage is relatively less. So one is the disease per se will dictate whether you should be doing urodynamics in that or no. The other thing that I take into consideration is the complexity of symptoms. So for example, if a stroke patient only has urgency incontinence, then you understand that then it's what is expected. But let's say the same patient has a high post-void residual urine, and you are thinking of a component of an underactive bladder, then to objectively manage these patients, you would probably need a invasive urodynamics. And third is any therapeutic intervention planned in neurourological patients. So for example, Parkinsonism patient has a poor uroflow and you're planning to do a TURP. It is mandatory that you should be doing a invasive urodynamics before you proceed. Now, one of the main reasons why we do urodynamics is to figure out which of these patients are at upper tract risk. When we say upper tract risk, we mean that the bladder pressures, or what are the signals that the bladder pressures are not conducive to the urine getting drained and for hydronephrosis or efflux to develop. So patients who have neurogenic detrusor overactivity, whether it is a high pressure detrusor overactivity, the amplitude is high, or whether it is lasting for a longer period, or if it is a compound detrusor overactivity. So these patients are at higher risk. The second category of patients who are at higher risk are those with poor compliance, and we usually take a cutoff of 20 centimeters to define that. We've all heard of high DLPP, and we've all heard that if the detrusor weak point pressure is more than 40 centimeters of water, it is detrimental to the upper tracts. So there was recently a paper from Italy where they have found out that 20 centimeters of water is possibly a more sensitive and specific cutoff to define detrusor weak point pressure. So the concept now is, if your patient is going to be on intermittent catheterization, then you try to bring the pressure as low as possible in order to preserve the upper tracts. Detrusor external sphincter dyssynergia, we've already discussed. That is a risk to the upper tracts, and systometric capacities of less than 200 cc will also risk the upper tracts. So there are some slides which have been taken from the INS library, and I acknowledge the same. Thank you. Any questions, sir? Should we go to case discussion?
No. So far we don't have question, but we'll keep it at the end. Pawan,
yes.
There are 3 residents who have volunteered along with your postgraduate, if they are,
Yes.
to discuss with you and interact with you.
Yes, sir.
And Kiran, if you can allow Amitabh, Samarth, and Sumed to have their audio and video on.
They are already allowed, sir.
Excellent. Thank you very much. Over to you, Pawan.
Okay. So, sir, I'll just share the screen again. And sir, is it visible?
Yep.
Okay. So, we'll take the first case. This is a 51-year-old male, no comorbidities. He had a traumatic D12L1 fracture for which fixation was done. Following this, he had retention of urine, and he was on an indwelling catheter for a month. Now, thereafter, for the last 1.5 years, he's been voiding on his own, poor stream, intermittency, abdominal straining. He's not had any urinary infections so far. He's constipated, passes stool once in 2-3 days. Recently, he's been diagnosed with PINES. And on examination, the anal tone is normal and the VCR is present. So how would you, anybody wants to take this, how would you like to proceed with this patient?
Yes, sir. This is Dr. Samarth here, sir.
Yeah, Samarth, tell me.
Actually, sir,
anything you want to know more in this?
So considering the history of the patient, I'd like to know the post-void residual urine of the patient.
Okay, one. Anything else?
If the patient has normal sensations of micturition.
Okay. Anything else? Anybody wants to contribute?
Sumed, Amitabh, if you have anything to say, please.
Actually, I can't see them, so it's difficult.
Please keep your video on, Amitabh. Sumed. Yep. Sumed is there. Sumed can keep his video on.
Yes, sir. Yes, sir.
Yeah.
So is there anything else you want to Okay, so we'll save some time. Yeah, tell me.
Yes, sir. Sir, I would like to know the basic voiding diary of the patient.
Okay.
The upper tracts as well as the post-vital residue. So based on these parameters, I'll do the UDS. So since it is a suprasacral lesion, so chances are there that upper tract deterioration may be there. So
So do you think this is a suprasacral lesion?
yes, sir.
So can somebody take this? That how do you define the level of a lesion? So you sometimes write that the lesion is this level. So how do you come to the level of the lesion?
Hello.
Yes.
Yeah. Sir, Samadhankar here. Sir,
Yeah. Tell me.
level of injury is decided by the sensory level of the injury.
Okay. So
Which level? Yes.
So I'll tell you how you do this.
Yes,
The level of the injury is not decided by the level of the fracture. That is one. The level of the injury is decided by the lowermost point where both the sensory and the motor components are normal. Okay, that is one. So, for example, if the level at which the sensations and the motor supply on both sides of the body, right and left, are normal, that will be the level of the injury. And the other thing which is to be noted whenever you look at the sheets of these patients when neurosurgery people are they are managing, the other thing which they note is whether the lesion is complete or incomplete. So one is the level of the lesion, the other is completeness of the lesion. So how do you decide whether any patient has a complete lesion or an incomplete lesion?
Sir, completeness or incomplete is defined on the basis of the sacral sparing. Sacral is
Yes.
yes.
Yes, very good. So if the so when you say sacral sparing, what do you mean?
Sir, perianal sensation and BC are present or not?
So if perianal sensation or rectal squeeze or BCR is present, which means there is sacral sparing, that is the only criteria which is used to say whether a spinal cord injury, whether the lesion is complete or incomplete. And the lesion is decided, we've already discussed, based on the sensory and the motor level. This lesion is somewhere where the fracture is somewhere where the spinal cord would be finishing, right? So at L1 is where you have the S234 the cord. So it's not taken for granted that this is a suprasacral lesion. Anyway, so what you asked for, I'll just give you what we have. So urine analysis was normal. If we look at the voiding diary, the frequency was normal. He was voiding around 300 cc each time. The upper tracts were normal. Pre-void was 400. Post-void was 180. Prostrate was 22 cc. And this is the Euroflow trace. How would you want to proceed?
So in this, the Euroflowmetry shows an intermittent flow where the flow is touching baseline multiple times, which gives us an idea that it might be because of abdominal straining that is voiding this way.
Okay. So what do you want to do?
So I would like to proceed with an invasive urodynamics for this patient.
But he says I've got no UTIs. I'm voiding. I am my post void is also. I'm voiding. Upper tracts are normal. There is no UTI. Would you want to do an invasive urodynamics?
Yes, sir. Even then, I like to do an invasive urodynamics because in the history you've mentioned that the patient is voiding by straining. So we'd like to know what kinds of bladder pressures which is generating and whether or not they're detrimental to the upper tracts, which might not have manifested yet, but could manifest at a later state.
Perfect. So ultrasound, when people say we should be doing ultrasound will detect the problem once it has already happened. the only way to preempt is if you have a urodynamic study. So this was the urodynamic study. Anybody wants to, you want to read it?
Yes, sir. In this case, we say that in the filling phase, the bladder is silent. There is no neurogenic reducer overactivity or anything, and compliance is okay. And when we see that voiding phase, in the voiding phase, we can see that the patient has generated a lot of abdominal pressure, and the uterus seems to be silent. The period is not generated here, so it looks like detrusor underactivity because the abdominal pressure he has generated, but there is no detrusor activity.
Very good. So filling phase, essentially he did not have any sensation for most part, and the filling phase is safe. There is no, the compliance is normal, detrusor overactivity, there is no detrusor overactivity. Filling was stopped at 500 cc. If you look at voiding phase, this is the vesical trace, this is the abdominal trace, and he has tried to generate, he has tried to strain a lot, and this probably is an artifact because of the subtraction. This is the detrusor comes from the subtraction of these two. But anyways, if this is not an artifact, it's an underactive detrusor or a contractile detrusor. So strong abdominal effort without any urination, without any void as such. Now, can somebody take this, that why is this EMG increasing? Is this DSD?
No, sir. Actually, it is because of the abdominal pressure that he has generated. This pressure is transmitted in the sphincters also, sir.
Yes, so you have to remember this, that a diagnosis of this, of DSD, can only be made if the abdomen, if the abdominal line is flat. If you're getting, if he's been straining with his abdomen, that will get transmitted to the EMG, can get transmitted to the EMG. So this essentially becomes a fallacious thing. So how do you want to now proceed? Do you want to allow self-voiding to continue? Do you want to add some drugs, or do you want to shift him to intermittent catheterization?
I'd like to start this patient on intermittent self-catheterization because he's voiding with a lot of abdominal pressure.
Okay, anybody else wants to take this? He says I'm voiding with Valsalva. So what is, and I've not had any UTIs. I'm more or less doing okay. Should he be shifted to intermittent catheterization? Okay, I'll take this for want of time. So when we talk of bladder expression, whether it is Valsalva or Creed maneuver, now what happens in these patients is, if you look at this diagram, the abdomen, whenever you apply abdominal pressure, this is not normal voiding. So this bladder neck is actually not opening. This is one thing which happens, so which builds up the pressure inside the bladder. If you look at the intravesical pressure, even though the detrusor pressure is negligible, the intravesical pressure has gone beyond 150. So one is that since this is not physiological voiding, this does not open. And the other problem is when they strain, this is transmitted to the pelvic floor also. So this causes a functional obstruction at the level of the membranous urethra. So you're actually squeezing from top, but you're also squeezing, you're squeezing from top to empty, but you're squeezing from here so as to not allow to empty. So this is not physiological. Bladder expression, whether Valsalva or Creed, is not physiological. You yourself are bringing in, the person is bringing in a component of functional obstruction. So many a times the emptying is inadequate. We've seen that it can lead to intravesical pressures can rise, which can be dangerous. More importantly, the pelvic floor is getting stressed. What does that mean? These patients over a period of time start developing piles, they start developing hernias, sometimes they come with a new symptom of stress incontinence, which was not there. So because the pelvic floor is getting stressed, they will it's getting weak, so they start getting these complications over a period of time. So overall bladder expression should be discouraged unless you can ensure that the vesical pressures are remaining within safe limits, and it should be replaced by intermittent catheterization in most patients. So any drugs you would like to prescribe? So I'll just take this further. There is no role of any methanicol or Urivoy or whatever, any parasympathetic mimetics in these patients. The standard therapy for these patients is intermittent catheterization. And so can you tell me what size of catheter should you use, and what should be the frequency of catheterization?
So 12 to 14 French would be ideal size for TIC in this male patient, sir.
What should be the frequency of catheterization? I mean, what do you tell your patient? How often should you catheterize?
3 to 4 hourly.
3 to 4 hourly. So I'll just take this for want of time. Size, correct, it's between 12 and 16 French. The frequency is about 4 to 6 times. So see, the idea is if the frequency is too high, then the chances of urethral trauma and stricture are more. If the frequency is too low and the volumes become more than 400, 500, then the chances of UTI increase. So you're looking at a mean frequency of 4 to 6 times, and you should be able to alter his fluid intake to a level where he's not emptying more than 400 odd every time he or she voids. Now, so I'll just go through this. There are 3 techniques described. One is sterile, which is what we do in our theaters. Then there are 2 other techniques described. One is clean and one is aseptic. Clean is what we do, what most of us do here, which means that you can be just washing your hands using a reusable catheter for intermittent catheterization. Whereas what is standard in the European countries is aseptic. And by aseptic, they mean that every time they will use a fresh catheter, and they will try to have a no-touch technique. Now, there is no data which says that aseptic technique is better than clean or single is better than multiple. Now, regarding catheters, you get hydrophilic catheters and also uncoated catheters. Again, there is no data to say that any of these are better. And in our country, we are usually using either PVC catheters or now more recently, the silicone catheters. Now, key factors for a successful IC program, it is extremely important that somebody who knows should explain how intermittent catheterization is to be done. Hand cleaning, meatus cleaning, catheter cleaning, extremely important, should be explained. Importance of lubrication, gentle handling must be, because so most of the times the IC is being explained by somebody who herself may not know what needs to be done. So you need to be careful here, and self IC is always better than a caregiver IC. Now, so not to this patient, if let's say somebody who cannot do intermittent catheterization, then the other option is an indwelling catheter. And the only thing I want to mention here is that suprapubic has lesser complications than the urethral. You should be changing catheters preemptively. So don't change catheters when they get blocked. They should be changed before that is going to happen. So median period of 2 to 4 weeks is there with silicone catheters, in which there is less incrustation compared to latex. Latex you may want to do a little earlier, but both are to be avoided wherever possible. One thing that I would like to clarify here is a lot of people, we often believe that if a patient is on an indwelling catheter, his upper tracts are safe. We believe that as long as he does not get a urinary infection, his upper tracts are safe because the urine is coming from the kidney to the bladder and coming out. You look at this. This is a study which was done over more than 20 years in about 300 patients. This is what happens to the compliance of the bladder. If you're doing intermittent catheterization, this is what was happening to the compliance. This is the graph with the self voiders, and this is the graph which is with the indwelling catheters. So do not be under this misconception that if you have an indwelling catheter, your upper tracts are safe. And this poor compliance in this was associated with reflux, was associated with pyelonephritis, with hydronephrosis, and with upper tract stones. So please remember that even though you've put in a urethral catheter or an SPC, they are more prone to worsening compliance, VUR, hydronephrosis, and upper tract stones. Another last thing in this section is, so this was a study where they looked at how patients did depending on how they were discharged. So this yellow line is showing patients who were discharged on an indwelling catheter. What happened to them over 30 years? Most of them continued to stay on an indwelling catheter. And this is, these are patients who were discharged. The green one is the patients who were discharged on a intermittent catheter. And it was still possible to keep some of them on, nearly 50% of them on an intermittent catheter up to 15 years post-injury. So very important, make all efforts that your patient is shifted to an intermittent catheter before he is discharged. Surgical options, I will not go into any into these because this is an area which is evolving. There is a LD muscle flap which they say that may help, but currently data on doing a surgical procedure for an underactive or acontractile bladder is not robust. We don't have anything on that. So this patient was offered, he opted for CIC. Again, follow up, be vigilant, like we've discussed. So no, we've not discussed. So you have to be vigilant because the situation can, from a safe situation, can suddenly turn into a dangerous situation. And up to 50% of these patients who are actually having a normal filling phase, they may develop a low compliant bladder over a period of time. So you can't just let them go thinking, I've done urodynamic once, this was a filling phase was normal and I don't need to do anything. So you need to repeat your study at 6 to 12 months. And for sacral injuries, you need to do your repeat urodynamics every yearly or at least once in 2 years. So any questions in this case, or should we go on to the, sir, any questions here?
I think anything is there, we'll keep it the end. You can go ahead with the, yeah.
I'll go ahead with the next case. Okay.
Yeah.
Okay,
We keep the same residents, or is there anybody else who wants to join? We keep with the same team? Smart, Amitabh and Smith. Are there more to join who wants to interact and discuss the case? Okay, go ahead, Pawan. Pawan, go ahead.
Okay, so somebody, okay, so I will just go up, share screen. Yes. So this is the second case. This is a 23-year-old male who had a cervical spine injury, resultant quadriplegia, went into retention, was on PUC for 6 months, and thereafter has been on a triggered void and condom urinal since 3 months. No UTI so far, constipated, moves bowel once every 2-3 days. The higher functions are normal. There is moderate spasticity. Anal tone is increased. BCR is present. So how do you want to investigate this patient? Anybody?
So again, I would like to go for an ultrasound KOB with a post-operational urine and a serum creatinine for this patient, and avoiding diarrhea.
Okay, so what we have here, what is this? Yes. So urine analysis was normal, creatinine was normal, upper tracts normal so far, pre-void is 150, post-void is 50 cc. So my first question is, after you get these spinal cord injury patients, what is the time that you should be doing your baseline urodynamics?
So the baseline should be done only after the period of spinal shock is over, which usually takes around 3 to 6 months.
And what is the what tells you that the spinal shock is over? If you see a patient, let's say with a suprasacral injury, what would tell you that the spinal shock is over?
So the exaggerated reflexes below that level, they usually subside by that time.
So BCR comes back in
Yes, that is
suprasacral
the first part. Yes.
lesions. Now, so now coming to so video urodynamics is the gold standard to assess these patients, and as he mentioned, it should be done at the end of the spinal shock phase, which most people would do it around 3 to 6 months. So this is the video UDS study, and can you read this?
It is showing a detrusor overactivity with leakage. The pressures generated seem to be around 120 centimeters of water. The bladder neck is open, the posterior urethra is dilated, and there is no evidence of reflux at the time.
So this is the vesical line, this is the abdominal line, and this is the detrusor line, and this is the EMG. So if you see at about so this was a high pressure NDOA at about 120 centimeters amplitude at a 60 cc volume, and he leaked about 20 cc. During this period, this sphincter activity actually increased. So this is, and because of that is what you see that there is obstruction at this level, and that is why this posterior urethra is dilated. So we continue to fill, and can you read this? So this is the portion that we already discussed. I think we are running a little. Yes, please.
Yes, sir. At the end, when we see that the voiding phase, patient has generated a lot of detrusor activity. The pressure is good enough, but along with that, he is also generating a lot of EMG activity in the sphincter, and the abdomen is silent. So this may be a case of DSD also. Associated DSD is there.
So this is a classical case of suprasacral injury where we are talking of neurogenic detrusor overactivity along with DSD. But I'll just show you something here. So this we had discussed, this is the NDOA and there is associated DSD. If you come here, there is again a NDOA along with the reflux rise in the EMG. If you look at this was actually abdominal tapping. This was being done so after this finish, this was started to aid voiding. So we asked him, so this is what induced this portion, these three traces. So this is actually what was being used for the trigger void, and this is the urine that was coming out by this maneuver. So NDOA again, high amplitude NDOA was coming, and with tapping, he was able to void a little more. So how do you think these patients should be managed? Anybody?
These patients should be managed with antimuscarinics. Along with for drainage, we can do CIC.
So which antimuscarinic and what dose would you prefer?
The solifenacin 5 mg/HS, or if not responded, then we increase the dose.
Any specific reason for solifenacin?
So it is more specific for the M3 receptors.
Okay. So antimuscarinic and CIC is the standard treatment for the suprasacral injuries. Now, the question which the patient attender asked is, we are doing triggered voiding and we have a condom urinal. So why should we not continue with it? Because the upper tracts have not been damaged so far. I mean, there is no complication which had come. So the question is, why not to continue with the triggered void? And the answer is that this urodynamic situation is not safe. He has a very high amplitude NDOA and inefficient voiding. Now, if with a smaller NDOA, if the voiding was efficient, which means the component of DSD was less, you could still consider it in a quadriplegic. But at least for this patient, sooner or later, he will develop upper tract changes if you allow the triggered void to continue. So triggered voiding has a very limited role. You will have to follow up these patients very closely if you want them to be on triggered voiding. The a prerequisite is the urodynamically it must be a safe situation. And how can you address, if they want to be on this, you can add a surgical sphincterotomy, which will then bring down the bladder pressures even lower. So overall, triggered void has a limited role, and first line will remain antimuscarinic and CIC. So antimuscarinics improve both subjective and objective improvement. The mean capacity increases by about 30 to 40%, and the detrusor pressure decreases by about 30 to 40%. So when you so you will get an idea as to how much if they are very small bladders, then you know that your antimuscarinic is not going to increase the capacity to a point where CIC will be feasible. But so you get an idea when you see the diaries how much your patient is likely to respond in terms of both the capacity and the pressure, because the mean difference is about 30 to 40. Now, antimuscarinics more or less are all the same in terms of efficacy, but in terms of side effect profile, they may differ. And one important thing that you should remember is that there are two drugs. One is derifenacin and the other is trospium, which should be preferred in patients who have cognitive dysfunction. So trospium does not cross the blood-brain barrier, and derifenacin has an efflux pump in the blood-brain barrier where it is pushed out. So for elderly population, if you are to use antimuscarinics, you should be using one of the two. So this was a young patient started on solifenacin 10 milligram CIC. Incontinence persisted. Now what to do? Anybody?
So we can either increase the dose or add another antimuscarinic to this.
Okay, so there are so within the neurogenic population, people have used double doses. People have used two antimuscarinics with double doses, and somehow they have been neurological patients have tolerated these. Now, of course, anticholinergic burden is a concern, because we all understand that this can lead to cognitive dysfunction. So if your patient is old, you will probably avoid it. But if he's young and botulinum toxin is maybe not affordable or something, there in those populations, you can see if you can upgrade, increase the dose and see if that helps. So coming to mirabegron, any role of mirabegron?
So no proven role as yet in case of neurogenic detrusor overactivity. But,
so mirabegron role is currently evolving, and even in combination, there are some retrospective studies. The prospective data was not encouraging for NDOA. There is some retrospective data now which is coming, but as of now, mirabegron does not have a proven role. So, but anyway, this patient received 10 milligram solifenacin, 60 milligram trospium with 50 milligram of mirabegron. Incontinence persisted. What to do next?
We can give botulinum toxin to him, sir. We can offer him.
What should be the dose of botulinum toxin, and how do you give it?
So normally we give 100 units, and it has to be injected submucosally, or some people will give intraductal also, and it is given at 20 sites, sir.
Okay, so I'll just cover this. So one botulinum toxin is basically given for the patient who's refractory to oral drugs. Now, unfortunately, what is refractory is not defined so far. Whether it should be inadequate efficacy with one drug, two drugs, single dose, double dose, both drugs, double dose, one drug, mirabegron, yes or no. So this is still a gray area, that when should you shift to Botox. But if you do decide to shift to Botox, Then they receive, for spinal cord injury patients, the starting recommended dose is 200 units. Whereas for patients who have a suprapontine lesion, for example, Parkinsonism, there most people use 100 units. And botulinum toxin would increase the capacity by about 50 to 60% and decrease the pressures by about 50 to 60%. Now, one important thing here is that there are people who are giving so botulinum toxin has been, it is approved for intradetrusor injection. If you look at the vial also, there is no approval for the for any other intra submucosal or, but there are trials which are looking at this, but the standard remains an intradetrusor injection. The sites are so in the two pivotal trials they used 20 sites, but that is not. There are people who found equal benefit with the lesser number of sites. So the sites is the sites, whether you should give it in the trigone, yes or no. Those are all areas which are controversial. But 200 units of intradetrusor Botox is the standards recommended starting dose for suprasacral spinal cord injury patients. Now, should you be giving an anti-muscarinic with botulinum toxin? The answer is no. The effect of botulinum toxin lasts for about 9 to 12 months, and repeat injections are efficacious. So so it's not that after 1 or 2 injections, and there's an interesting thing which has been seen, that if a patient who receives botulinum toxin fails, if you give a botulinum toxin of another brand, of another company, if you switch the toxin, the likelihood of it working is twice as much. So if you were giving A and you give B versus giving A again, the chances that it will work is 50% more than using the same toxin. Again, this patient received 200 units and he is doing well. Now, here I forgot to tell you that before you give botulinum toxin, you must be sure, you must have counseled that somebody will be doing CIC for him. He's tetraplegic, he will not be able to do CIC. So unless the caregiver agrees to CIC, botulinum toxin cannot be given. So in this case, they had agreed. Now let's say CIC is not possible. Then what are the options? Again, same patient, quadriplegic, CIC is not possible. The caregiver says he cannot do CIC. What are the options?
So you can add a sphincterotomy and teach him to trigger void. If the
So one is what he was doing. Yes, one is what he was doing to allow him to trigger void, and the other is he will, if nothing else is possible, he will have to go on to an indwelling catheter. I will not take the sacral root rhizotomy in SARS because we don't have it here, so it will become more theoretical. Now, what do you think? What do you think is the patient complication rate based on the bladder management? So whether he was undergoing intermittent catheterization or PUC or SPC or voiding, how do you think the complications differ amongst these groups? Because ultimately patient counseling will involve. So if he says, why should I not be on an indwelling catheter? Why do I have to do CIC? It's more comfortable or whatever. So what do you think is how do the complications differ depending on the bladder management that is being selected?
Sir, highest, lesser with the self-voiding and highest with the indwelling catheters.
So I'll just, this was a very interesting study which they did over nearly 2 decades. This lowest line, this green line, is intermittent catheterization. So the lowest complications occur if the patient is on an intermittent catheter. This next line is of patients who are doing triggered void or whatever. But please understand here that only patients in whom detrusor pressure was less than 40 and PVRU was less than 100, they were allowed to continue in this, they were allowed to take this triggered void approach. If they were outside this zone, then they either had to shift to an indwelling catheter or had to shift to an intermittent catheter. So don't be under this impression that triggered void is, I mean, I hope to have brought this point that only triggered void or self void is only coming in if you are able to maintain a low pressure bladder. Okay, so this is the intermittent catheter line. This is the triggered void line. This is the SPC line, and this is the perurethral complication line. Now, if you notice between the suprapubic and the urethral catheter, suprapubic catheters have lesser complication as compared to the urethral catheter, but this complication evens out by about 20 years. So if they're going to be on catheters for 20 or more years, then both of them are essentially have the same level of complication. For lesser periods, SPC has been shown to have lesser complication. So it stands to reason that try to get your patients onto an intermittent catheter, very important. If you cannot, see if you can get them to empty without an indwelling catheter while maintaining low pressures. And if that is not possible, then maybe SPC will be a better choice over the urethral catheter. So do we have time? Should I?
Please go ahead. This case is interesting. It's pediatric, so, it's 11 years.
Yes, sir. Yes, sir. Yes, yeah. Sir. So this patient, this was a male child who since birth was having continuous dribbling and nocturnal enuresis with fecal incontinence. Now he came in 2009 when he was about 11 years old, and he was operated for this neurosurgical condition. He had a lumbar lipomyelocele. Now, after this surgery, the fecal incontinence portion improved, but his urinary complaints did not, for which he came to us after a couple of months. Now, when he came to us, the complaints were the same, continuous dribbling of urine and nocturnal enuresis. The examination, the anal tone was lax and the BCR was absent. The bladder diary, essentially he was leaking multiple times, and the functional bladder capacity was only 90 cc, and the creat was normal, the urine routine was normal. He had an ultrasound with him which showed left hydroureteronephrosis with a pre-void of 100 and a post-void of 10. So how would you want to proceed in these patients? In this patient, sorry. Anybody?
Amitabh, you can take.
So we can go for a video urodynamics for this patient.
Okay, so okay, one, you want a video urodynamics, anything else?
So to further evaluate the left hydroureteronephrosis to be because of reflux or obstruction, we can get done a MCU separately after a DTPA scan.
Okay. So for this, okay, so we did an MCU, or maybe he had an MCU. This was the cystogram. You want to read this?
Yes, sir. He's showing a grade 5 reflux on the left side with no reflux seen on the opposite side. The bladder contour seems to be irregular, and the bladder neck is open. However, you do not see voiding further.
Yeah. So this is a classical, how a neurogenic bladder would look, and you have left grade 5 reflux. When subsequently we did a DTPA scan, and the left kidney was essentially non-functioning. Now, this was followed by a urodynamic study. And so before we do a urodynamic study, what are the fallacies that in urodynamics that you may get in this patient?
So we might get normal pressures because the pressures, because of pop-off mechanism, could have the volume of urine could have reached the upper tracts, but the pressures would not rise as anticipated.
Perfect. So if your urodynamics is normal, that or the pressures are not rising significantly, that may not mean much, because you have a pop-off mechanism where the urine is getting accommodated. So a normalish urodynamic may not mean much, but if the urodynamic shows abnormalities, that has even more significance. So this was the urodynamic study. You want to read this?
So this trace is showing detrusor overactivity with worsening compliance, which is classical of a compound detrusor overactivity. However, I cannot appreciate any leakage of urine seen, and the pressures generated are in excess of 100 centimeters of water.
So essentially, there are two important things. One is this pattern is what we call as a compound DO. What does a compound DO mean? Compound DO means that even though this is phasic, but the general trend is upward. This general trend is going upward. Yeah. If it's pure phasic, it will come back, go up, come back, go up, come back. But this general trend is going up. So this is one important thing, that this is a compound DO. The other, which is a risk factor for upper tract damage. The other thing is, if you look at the period of DO, that is more than 1/3 of the period of the study, which again is a risk factor for upper tract damage. And the third factor which is evident here is that in spite of these DOs reaching more than 100, there is no leak, which means, there is minimal leak, which means he has a high detrusor leak point pressure, which again is a risk factor for upper tract damage, and which is what happened. So what do you now want to do with this patient?
This patient has got a small bladder capacity and left kidney non-function. So we can plan for a left side nephrectomy along with augmentation cystoplasty for this patient.
Okay, so one thing which I want to clarify here before we go further is, so sometimes these patients are counseled for left nephrouretrectomy. Please bear in mind that this is actually the pop-off. And whatever the right side kidney is getting preserved, it is getting preserved because of this pop-off. If you do a left nephrectomy without addressing the bladder, the right kidney will get knocked off within the next 6 months. So please be careful whenever you're doing nephrectomy in such patients. It cannot be done in isolation. It will have to be done with a procedure which is reconstructing which is addressing the bladder. Otherwise, you've taken out the safety valve or the pop off. So the other kidney will start getting damaged. So he was counseled for Botox, did not have was not affordable, so planned for nephrouretrectomy with augmentation cystoplasty. Now, now there are various patch choices, and most people would use an ileum. There are some people who use a colon, and but for this patient we had used a stomach patch. And if you see, this is the stomach patch which has been so this is the head end, and this is the foot end, and this is the stomach patch which has been isolated on the right gastroepiploic artery, and it's got through it's got from behind, so through the transverse mesocolon. And this was so post. So what should decide your patch choice? How do you decide? So what are the things in which help you to decide whether you should use an ileum or any of these patches?
So the metabolic complications associated with the bowel are higher as compared to the stomach, but the stomach has got a complication of hematuria dysuria syndrome. That is the only thing that That is a bothersome thing. And otherwise,
so everybody has their own choice. One good thing with stomach is that if they are continent, they don't trouble you too much. The mucus recurrent UTIs, they don't happen. And stomach is also a very good patch if you're using it in CKD patients. So patients who have CKD, their management of acidosis and CKD actually improves if you use a stomach patch. But for the routine patient who needs an augmentation cystoplasty, I don't want to send this message. For the routine patient who needs an augmentation cystoplasty, the standard patch that is used is the ileal patch, and some people use the colon patch. Now, can you tell me how you do this augmentation cystoplasty? What is the classical way of doing an augmentation cystoplasty?
it depends on the, sir, actually, in adults, we take 10 to 15 segment of 15 to 20 centimeter of yum, and then open it at the antimesenteric border, and then at the dome, we anasmose it with the bladder after.
So the only thing I'm trying to reach here
Sir,
is...
we want to...
Yeah, please.
Sir, in augmentation cystoplasty, we want to preserve the trigonal part with ureteric insertion, and then we apply the patch over the dome.
So the only thing I was trying to get to was, it is very important for augmentation that you must have nicely bivalved the bladder. This is, if you see, you must bivalve the bladder properly. If you do not bivalve it properly, you actually get a diverticulum like kind of thing. So that is what classically clamp cystoplasty is, that you bivalve the bladder and then apply the patch on top. So this was so post procedure, how would you want to follow up these patients? So, okay, so we're running, I think, out of time. So this was the pouchogram. I think it's the seventh year or something. So this is the pouchogram, and this was the kidney is doing well, and this was the follow up UDS with bladder which is fairly now compliant. So we can take some questions, sir. If
Pawan, I'll just see the chat section. There was one question which was related to case 1, where we had lesion at D11 and D12, and the question is the role of alpha blockers in that.
Sir, alpha blocker essentially in the neurogenic population are only used to decrease the bladder pressures. That is the only where it has been used. It is not so in a suprasacral lesion. If there is a component of BPE, if there is a component of prostate, then you're using alpha blocker like you use. But for a patient who has a lumbosacral injury and he's voiding with abdominal pressure, the obstruction is actually at the pelvic floor. So alpha blocker per se will not, like Bithanicol, alpha blocker per se does not add in that patient.
Okay. Another question is role of sacral sparing in the management of neurogenic bladder.
Role of sacral sparing. No, sacral sparing essentially means, no, I didn't get the sacral sparing essentially means that the injury, if it has spared the sacral cord, then it is an incomplete lesion. I didn't understand the question. Sacral sparing.
Yeah, for me also. S. Kumar, if you can repeat your question and put in the chat box again, that will be great. So I move to the next question. This is from Kaushal. How urodynamic study is done after augmentation cystoplasty?
Standard fashion, but video should be preferred because these patients will not be having sensation. So you feel, so for example, these augmentation cystoplasty patients would be on intermittent catheterization, and let's say their voiding volumes are 400, 400, 300, 400, 500 cc. So we fill only till that much. You fill to about 350, 400 cc. So during that period, if the bladder is safe, then that solves your purpose, that the augmentation cystoplasty has worked. You don't need to keep filling because they will not have sensations.
Okay. This question, I think S. Kumar has repeated his question. Difference in the management of incomplete and complete lesion of the spinal cord.
So incomplete lesion, if you look at, if you're referring to case 1, which is the lumbosacral, case, there is something called as intravesical electrotherapy, where they put in a catheter through the urethra and they stimulate from within the bladder. And intravesical electrotherapy has been found to improve the sensation in patients who have incomplete lesions. But and then there are some people who have been trying sacral neuromodulation in incomplete lesions. But otherwise, broadly, there is no other difference except that the electrical therapies can be used as an option in these incomplete lesions.
Okay. So the last question is the role of long-term suppressive antibiotics in cases of recurrent UTI after augmentation.
So role of long-term
suppressive antibiotics.
So suppressive antibiotics, see, if you're having recurrent UTIs in neurogenic bladder, it must be, that is the first thing for you to go in and reevaluate your patient again. So you will always find something if there is somebody who's having recurrent UTI. Either his intermittent catheterization protocols are not correct, or the compliance has worsened, or so something. So recurrent UTIs is one of the indications to go back in and do a urodynamics. So if you're getting recurrent UTIs, instead of putting the patient back onto suppressive antibiotics, you first need to go in and evaluate him again, because you would be missing something in most cases.
This is again a question from Aditya, which I think pertains to case 3, which is the non-functioning kidney. Can the dilated ureter be used for augmentation in these patients? That's his question.
Yes. So, sir, ureterocystoplasty is a very good procedure because it essentially takes out all the problems that we have in putting an intestinal patch away. The mucosal problems, the metabolic problems, all those problems are taken away. But the problem with the ureterocystoplasty is one, it can only obviously be used where the kidney is non-functioning. So you're removing the kidney and you use the ureter for patch. The volume of patch that you get with a ureterocystoplasty is not that big. So if patient had a good capacity bladder, which was poorly compliant, which means the capacity is good, and your intention is you want to bivalve the bladder so that the compliance will improve, and then you put a patch, that would work. A ureterocystoplasty would work in that patient. But if you look at this patient, his bladder is too small for the ureter to actually augment from a capacity point of view. So ureterocystoplasty is more useful where there is some capacity, and the main reason for you to augment is the pressure.
Yeah. I think that was all from the chat section, Pawan. I think you have very nicely covered the first overview, which has enlightened all the radiants about the subject of neurovesical dysfunction. And over that, when you discuss the 3 cases, I think the whole spectrum of neurovesical dysfunction was covered. The 3 candidates who volunteered, I think they were probably a little prepared for your class, and I think they were very, very pertinent in answering your question, and they were to the point. And I could sense that they had a little bit knowledge about the overall conceptual management of neurovesical dysfunction, and they did it well. I think on behalf of, before I hand over to Dr. Rajiv Sud for his concluding remarks, on behalf of ISU USI, it's indeed a pleasure to propose a vote of thanks to you. This class has been attended by more than 60 people, still they are logged in. And I think this has been taken very well by all the residents in staying for these 1.5 hours online, and staying interactive and answering your doubts, the question which you have answered extremely well. Over to you, Dr. Rajiv Sud.
Thank you, Dr. Arun. And first of all, big thank you to Dr. Pawan Vasudeva. So well he has demonstrated by line diagrams, by interactive discussion, and also addressing all the queries of the residents, and a large number of residents today attended. And this will definitely add to their knowledge and day-to-day practice. And also it will it will pave the way for handling the other subspecialties also, by taking guide from Dr. Pawan Vasudeva's intricate descriptions and all the way he has given real teaching lecture. And these virtual classrooms and distant learning is becoming more and more successful. I'll request all the residents also that when it is posted in the archives, they should take advantage of all the lectures. And I am repeating that this is our effort of uniform curriculum. Urological Society of India is committed to provide uniform education throughout India, and also the new competency-based curriculum, which is getting inculcated into the medical teachings by National Medical Commission. This is the first step. That is the first two levels of competency. They are the knowledge and know and know how. And that is what exactly Dr. Pawan Vasudeva has imparted. And after that, it comes show and show house and how. And after that, the fifth level is the performance. And Euromat programs we are going to do because of the COVID pandemic. The physical Euromat programs are not happening, but all the residents be prepared. If the COVID incidence is going down, the Olympus facility, which is with us at Gurgaon and other places, that is going to be functional, not very soon, but in the next year. 21 March is the slated dates, when we can hope that again the other components of Euromet program will start. So happy learning, and all the credit again goes to the USI Council, Dr. Arun Chawla, Dr. Pawan Vasudeva especially today. And the topic which was chosen today, the full justice has been done to that. And this will be very, very useful for even examination for which the residents are preparing. Once again, thank you very much. Thank you, Dr. Pawan.
Thank you, sir. Thank you. Thank you very much.
Dr.
Yeah, just will add, sir, for the residents, if you have concentrated well in the beginning, the Madersbecker classification which he has put, showing the detrusor and the sphincter, which can be normoactive, overactive, and underactive. Same for sphincter, which can be normoactive, underactive, or overactive. If you make all this combination of detrusor and sphincter, you will not miss any lesion of the neurovesical dysfunction. And when he was just explaining you the urodynamics, so you have to concentrate how he's talking. He's talking in filling phase, and he's talking about voiding phase. In filling phase, he talks about the detrusor and changes in the detrusor, the sensation compliance, and the DO. and he talks about the sphincter. In voiding phase, he talks about the pressure, he talks about the sphincter. If means in nutshell, in 3-4 slides, he has summarized the whole neurovesical dysfunction so efficiently and so smoothly. If you concentrate on these 4-5 slides, you are not going to miss anything in the neurovesical dysfunction, and your management will be right to the pathology which you detect on UDS, which he has nicely described. How to decrease the pressures, how to improve the voiding, keeping in view the quality of life of the patient. Yeah, thank you, Pawan. Very nicely done. Very nicely done.
Thank you. Thank you
I
very much,
agree
sir.
with you, Dr. Arun.
Yes,
The
sir.
lecture name should today should have been Neurovesical Dysfunction Made Easy, because this is
Yes,
one
yes,
topic
yes.
which
Absolutely true, sir. Absolutely true. Absolutely.
everybody wants to understand, and he has done a very good job and
Extremely well. Extremely
full
well.
justice.
Thank
Thank you.
thank you, sir.
Thank you to all the
Thank you,
residents
sir.
for joining.
Thank
Thank
you.
you to
Thank you.
our USI office team. Dr. Rajiv TP is not there and at present, and he was there in the beginning. And Navneet and the team all are to be thanked. Thank you.
Bye, sir.
Good
Thank you, Pawan. Thank you. Bye,
Thank you,
everyone.
sir.
Bye.